So welcome to this Healthcare Biotechnology European Biotech Week webinar. The title of our webinar is At the Cutting Edge of Biotechnology for Cardiovascular Diseases, a World Heart Day Special Edition. So as you will all know, we are today on World Heart Day. So as a team, we decided to organize a special themed webinar to pay tribute to the work that's being done in the area of cardiovascular diseases and the link to biotechnology. So next slide, please. First, just a little bit about EuropaBio. So EuropaBio is the European Association of Biotech Industries, and we represent corporate members and national associations from all over Europe. And we have a number of different councils within EuropaBio. So we represent the broader biotech industry. So we have a Healthcare Biotechnology Council, which is organizing this webinar today. We also have colleagues who work in the industrial biotech sector. We have a National Biotech Associations Council, and we have an SME platform. And for the Healthcare Council, our activities are broadly arranged around three areas: so innovation, investment, and excellence in European healthcare biotechnology. Now, within those three terms, we also drill down a little bit further in our areas of activity. We cover those under the terms of science, regulation, accessibility, growth, infrastructure, and competitiveness. There's a number of activities that we engage in throughout the year, and this is one of them, being our webinar during European Biotech Week. Let's go to the next slide, please. So just a little bit on our structure to get you familiarized with what we do at EuropaBio in the Healthcare Council. We have our main sort of decision-making body, the Healthcare Council. We have representatives from all of our members in this. Within that, we also have a number of technical working groups where we provide responses to consultations, we produce position papers, and we engage with relevant stakeholders in the community. Next slide, please. So as said, our webinar is taking place within the European Biotech Week, which is now celebrating its 10th edition. We have almost 100 events across multiple European countries, and we've partnered with more than 100 organizations to organize a series of virtual and face-to-face events. So this is the third edition from the team. There was also an opening session you can catch the recording of from earlier this week. There was a session from our industrial biotech colleagues. You can also catch that recording, and this session will also be recorded, I should just say, for you to circulate to colleagues post-webinar. So apart from boring me, you've actually got some really interesting presenters today. So we have Florian Cronenberg from the Medical University of Innsbruck. We have Lina, I'm going to struggle with your surname, Lina, Limperopoulou from Novartis. And we have Marius Gianta from FH Europe. Next slide, please. So we've got a couple of different presentations from Florian and from Marius, and then we'll hear from Lina, and then there'll be an opportunity for everybody to ask questions and interact with the audience. And before that, I'll just give a very, very quick overview of what are biomarkers, because this is one of the main themes of what we're going to be talking about today. So next slide, please. Before we get into that, I'm mandated by the team to encourage you all to participate and contribute in the session today by putting your questions into the chat, by tweeting or posting on social media, and to share the recording afterwards. I have a hand up from Jose. I don't know if that's on purpose, or can everybody hear me okay and see me okay? Yeah, okay, then I will continue. Next slide, please. Next slide. So before we get into the really interesting speakers, let's just cover a couple of the basics for our webinar today. And I'd just like to do that by saying, what are biomarkers, talking a little bit about why they're important, talking about why they are relevant to the discussion of healthcare biotechnology, and what some of the issues are that we face. Next slide, please. So the European Medicines Agency has kindly provided a definition of a biomarker for us to get started. And they describe this as a biological molecule found in blood or other body fluids or tissues that can be used to follow body processes and diseases in humans and animals. Next slide, please. A couple of quick points on why biomarkers are relevant and important and why we're focusing on them. Well, we can use biomarkers to understand disease and also to develop and use appropriate treatment and prevention strategies in many different types and many different therapeutic areas. We can use biomarkers to detect disease and to predict outcomes of disease, as well as the prevention and treatment aspects. We can use biomarkers ultimately to benefit what we do for our patients. Next slide, please. So what? Why is it relevant to healthcare biotechnology, and why have we brought colleagues around the virtual table today? Well, there's been a lot of discussion in the last 10, 15, even longer years about the personalized medicine or personalized medicines. And the use of biomarker testing and technologies in practice is part of this movement towards more personalized treatment and care and prevention. And we know, and particularly with some other therapeutic areas like in oncology, that there's been a rapid development in genomics over the last 2 decades. And these technologies offer a significant potential to improve health outcomes and also to reduce the burden on healthcare systems. Next slide, please. So that's the nice theory, but there are a couple of issues, and the other speakers will also touch on this, that we have to overcome to get the most benefit from using biomarkers in clinical practice. So the health systems generally need to make a couple of evolutions and to make a couple of points of progress to ensure that the regulatory and reimbursement systems are able to get the most out of personalized medicine, including the use of biomarkers. There's a specific need to integrate biomarker testing into healthcare systems and international policies and best practices. We'll be hearing a little bit more about best practices and guidelines later on. And there's currently, specifically as it is World Heart Day today, there's a lack of healthcare systems guidance on cardiovascular disease screening strategies. And so that's why we've got 3 speakers lined up after me to talk in more detail about that. So next slide, I'd like to introduce Florian Cronenberg again from the Medical University of Innsbruck, who's going to talk to us about LPA. Over to you, Florian.
Yeah, thank you very much for this nice introduction. I will try to share my screen now. Okay, welcome this afternoon. I will talk about Lp(a) as a biomarker, and I'm working already since 30 years in that field, and we had lots of ups and downs. And I have the pleasure to introduce today to you the new consensus paper on Lp(a) after a long run, you could say. We came with this new consensus paper a couple of weeks ago. And I had the pleasure to, together with Samir Moro and Eric Strauss, to co-chair this group of people who are all experts in the field of Lp(a). So we had the first consensus paper in 2010. In the meanwhile, a lot of novel epidemiological and genetic studies became available. And this helped us now to shape new and novel recommendations and how we can incorporate Lp(a) in clinical practice. So first, about the epidemiological and genetic findings. When we're talking about Lp(a) as a risk factor for a cardiovascular disease, we have first to look how often can we observe elevated Lp(a) concentrations. So in roughly 70% of the population, general population, we have Lp(a) concentrations up to 30 milligram per deciliter, or the other unit is nanomole per liter, up to 75 nanomoles per liter. And we can say in those people, the risk for myocardial infarction is not increased. Then we have roughly 10% of the population with Lp(a) between 30 and 50 milligram per deciliter, where the risk is elevated by 30 to 40%. And then we have the group with Lp(a) above 50 milligram per deciliter, or 125 nanomoles per liter, so 20%. And in that case, the risk is increased by 50 to 200%. So now you could say, what is there a linear relationship? And we investigated that very intensively in the consensus paper using data from the UK Biobank. And you can see on the left side that the association between Lp(a) and major cardiovascular events is continuous. So we can clearly say the higher the Lp(a) concentration, the higher is the risk for cardiovascular outcomes. And we observed this not only in the white population, we see this also in the black population. Of course, the confidence intervals are much wider here because the sample size is not so big, but the estimates are pretty much the same. So there's a linear association, you can say, and independent of ethnicity, therefore Lp(a) measurement is relevant globally. So the first studies were shown to showed an association between high Lp(a) and coronary artery disease. In 2013 only, the first bigger studies came out and showed an association with aortic valve stenosis. And for these two entities, the associations are really very, very strong. But also associations with heart failure, total and cardiovascular mortality, stroke, as well as peripheral arterial disease. But for those endpoints, it seems that a higher concentration is required to be associated with this increased risk. So why do we know whether Lp(a) is a causal risk factor for cardiovascular disease? And this was a really long discussion, but the solution started already in the early 1990s. Here I bring you a cartoon about the genetic variability in the Lp(a) gene. And in the upper part, you can see a size polymorphism, which we call the Gringo 4 repeat polymorphism. And when you look at this cartoon here on the molecule of Lp(a), we can see here this apolipoprotein little a, and this have this kringle structure here. And depending on the genetics, people have different number of these Kringle 4 repeats, as we call them. And those who have a low number of Kringle 4 repeats, we call them small isoform carriers. They have a median very high Lp(a) concentration of around 50 milligram per deciliter. And those who have a large number of Kringle 4 repeats, they have on median relatively low Lp(a) concentration. And the isoform size is very strongly genetically determined. And we know that those people who have these small Lp(a) isoforms, they have a more than twofold increased risk for cardiovascular disease, as it was shown in the meta-analysis and also later studies after this meta-analysis. Let's come again back to this cartoon here. Here we have two different SNPs described the first time by Robert Clark, and they were investigated very intensively in the literature. And they were claimed to tag the small Lp(a) isoforms. And here in the consensus paper, we made a very interesting investigation that we looked at those people who do not carry one of those two SNPs. We use them as the reference group. They have really low Lp(a) concentration on median 40 nanomole per liter. And those who carry one of those isoforms, one of those SNPs here, they have 10-fold higher concentration. And those who carry two of those SNPs here, they have 262 nanomoles per liter, as we can clearly see here. And combined with that, the risk for cardiovascular outcomes increases tremendously to almost 50 and almost 90%. Again, coming back to this cartoon here we have two splice site variants, which have pronounced Lp(a) lowering effects. We have investigated this very intensively in a large cohort. And this cartoon looks a little bit complicated, but the most important thing is both splice site variants are quite common, frequency of 22 and 38%, and they have a pronounced Lp(a) lowering reduction effect. And carriers of both variants are quite frequent. We can see then in 5% of the population, they have a massive LPLA reduction. And you see those people who carry both splice site variants with the red arrows here, and in the different isoform groups here. And those who carry these two splice site variants have concentration between 5 and 10 milligram per deciliter, so very low LPLA concentrations. And both are, besides the cranial 4 repeat polymorphism, the two variants which have the most strongest effects on LPLA concentrations. So together with this genetic variability and also other variants explain roughly up to 90% of the LPLA concentration, so a very strongly genetically determined trait. And the next question was, do those who carry these two variants with this LPLA lowering effects, as we can see in this cartoon here, whether they have also a decreased risk for cardiovascular disease? Yes, we investigated this in the UK Biobank, and we have seen that those who carry both variants have a 12% lower risk for cardiovascular disease. And if we compare it to the people who carry the Clark SNPs, as we call them always, they have only a 50% risk for cardiovascular disease. So if we summarize that, the Mendelian randomization, we call this Mendelian randomization studies, there are LPLA increasing genetic variants as the small isoforms, so the Clark SNPs. They show a strong association with high LPLA, a strong association with cardiovascular disease risk. And when we can draw this triangle that way, then we get a really strong support for a causal association between LPLA and cardiovascular disease. And on the other hand, we have the LPLA decreasing genetic variants, like the two splice site variants associated with low LPLA, strong association with a decreased risk for cardiovascular disease. So this is a strong support that the LPLA gene is causally related to cardiovascular outcomes, and by that also the LPLA concentrations. Couple of words about LPLA testing and measurement issues. We recommended in the new consensus paper that LPLA should be measured at least once in all adults to identify those people who have a very high cardiovascular risk. We gave also some recommendations when it should be screened in young people and also in terms of family cascade screening. So how can we incorporate LPLA in risk estimation? And I think the next slide is probably the key figure of the entire consensus paper. I will guide you through this a little bit in more detail. On the y-axis, we can see the estimated baseline absolute lifetime risk for a cardiovascular event. And on the x-axis, we can see the baseline risk categories based on traditional risk factors. So if we go from the left to the right, then the risk is increasing depending on the number of risk factors someone has. And in the bars behind, we can see how the risk changes with increasing LPLA concentrations. And on each end of those bars, we can see the additional risk above the estimated baseline risk, which is caused by the respective LPLA concentration category. So in that case, the risk for that person, those persons with 25% baseline risk, if they have an LPLA concentration of 150 milligram per deciliter, the risk is increasing by further 43% to 68%. So a tremendous increase. And I will guide you through examples here. When we have persons with 50 milligram per deciliter LPLA concentration, in case of a baseline risk of 5%, this concentration of LPLA increases the risk to 7%, or from 15 to 21, or from 25 to 35%. So this is a 1.4-fold increase in risk by this 50 milligram per deciliter. When we go more to the extremes with 150 milligram per deciliter, then we can see that the baseline risk is increasing from 5 to almost 40%, from 15 to almost 41%, and from 25 to 68%. So this is a twofold risk increase by this high LPLA concentration. And if LPLA is not considered in the risk estimation, the absolute risk might be underestimated substantially. So how can we manage people with high LPLA concentration? We have at the moment no specific LPLA lowering drugs already in the clinic. We have it in trial. And therefore, we can only say early traditional risk factor management is really important and recommended, especially for those people who have the high Lp(a) concentrations. So that means each person who has high Lp(a), all cardiovascular risk factors should be optimally addressed as the different guidelines recommend. In some countries, also lipoprotein apheresis is a possibility. We do no longer recommend niacin and also not the routine aspirin because of high Lp(a). If it is indicated for other reasons, then of course it can be used. It is very important that the prevention starts very early in life. That means if we have, for example, here a person with 120 nanomoles per liter, which is roughly 50 milligram per deciliter of Lp(a), and we start already to decrease, for example, LDL cholesterol at the age of 30, we have it only to decrease by 0.4 millimoles per liter, but lifelong. If it is only at the age of 60, it will be 0.8. And of course, if people have very high Lp(a) concentrations, then the LDL lowering has to be much more. But we cannot lower the risk which is coming from Lp(a). We are lowering only by that intervention the risk which is coming in that case from LDL. And I would like to point you to a very nice tool which you can find on this website here, which was provided by Brian Ferencz, which is the Lp(a) clinical guidance, where you can put in all the major risk factors of a particular person, here in case a person with 45 years of age. And then it gives you a curve which shows you the risk of having a heart attack or stroke until the age of 80, which is in that case 20%. But you can also read it for the age of 60 or 10-year risk or whatever you like. And this is in the assumption that the person has no elevated Lp(a). What happens if a person has additional risk caused by Lp(a), let's say from 150 milligram per deciliter, then it draws a second curve, the red one, and we can clearly see that the risk is increasing dramatically to above 40%. But we can also, and this is very nice in this calculator, what happens if you change now the following risk factors like LDL and blood pressure. And in that case, we assume that the LDL is lowered by 50 milligram per deciliter and blood pressure by 10 milligram mercury. Then we can see a third curve and we can see that the risk is going down. But of course, if we go to the extreme Lp(a) concentration, the main part of the risk is attributable to Lp(a), and by that we cannot simply manage this by managing the traditional risk factors. Of course, we will bring down the risk which is coming from the general risk, but we cannot bring down the risk which is coming from Lp(a). And for that reason, we need specific Lp(a) lowering therapies which are under development. And here are these different options. For example, Belacarsen is an antisense oligonucleotide therapy with a monthly dosing. The outcome trial, phase 3 trial, is expected to be finished in 2025. Then we have two siRNA technologies, Olpasiran and SLN360. They are in earlier phases like phase 1 and 2. And all three possibilities, treatment possibilities, lower Lp(a) up to 80, even more than 80%. So this is really good news, and we have to expect, we have to see what the outcome trials will show us. So why should I measure Lp(a)? Lp(a) is a wonderful biomarker, I would say. Often the question is raised, why should I measure Lp(a) when I cannot lower it? It's a causal risk factor. It's a frequent risk factor. It's helpful for risk estimation, and I can already act now, not directly on Lp(a), but in case of high Lp(a), then I have to really strictly act on the risk factors which can be influenced. So there is no need to wait. Measuring Lp(a) is now the goal, and to do it without ifs and buts in the future. So if I summarize here, what in a nutshell, what is in the consensus paper, you see here this linear association between Lp(a) and cardiovascular outcomes. That is a new risk factor for aortic valve stenosis. We did not talk that it's no risk factor for venous thrombosis, and very low, very, very low concentration can be associated with an increased risk for type 2 diabetes, an observation we do not really understand. And Lp(a) should be measured at least once in adults. interpretation of LP, please always in the context with the other risk factors to see about the absolute global CVD risk. And an intensified risk factor management by lifestyle modification and medication should be the first goal. And of course, we are waiting for the specific Lp(a) lowering therapies. And here you can see the website from the ES where you can see also the slide sets and download them, and also this Lp(a) risk and benefit calculator. Thank you very much for your attention.
Thank you so much, Florian. A really fascinating presentation and a great start to our webinar here. I see the clear message amongst others, that this should be measured at least once in adults, and I think that's a clear message that has come through here. Thanks also for being available, on such a critical day for your profession, and also for sharing these hot off the press publications, directly relevant. I see we're getting some questions coming in already. Perhaps we could save these for the end. We have a dedicated section of the session for question and answers. So I'd like to thank Florian for your presentation. I have to say I've never heard a box and whisker plot described as a cartoon, but I think you did well to demystify some of the complexities of the data you're presenting, and I think that's much appreciated by our audience today. So thank you, Florian, once again.
You're welcome.
Let's move on then to have our colleague Marius, who will also share his slides from his own computer. So Marius, over to you.
Indeed, thank you so much, Jamie, for the introduction, and as well EuropaBio for inviting me today. Indeed, the topic of my presentation will refer to patient experiences with biomarkers for cardiovascular diseases, but in fact I will discuss, inspired by Florian, and I will try to broaden a bit, starting from your presentation, Florian, this new area of personalized medicine actually intersecting cardiovascular diseases and cardiovascular health. And I think the Lp(a) facts, as well the FH development, and I will refer to this soon, build a very strong case for what is called 4P medicine, standing for personalized medicine, for participatory medicine, for predictive medicine, and for preventive medicine. And yes, I will address all these issues from different perspectives. First of all, on behalf of FH Europe, I'm a member of the board. I'm a trustee of FH Europe, as well the chair of the policy committee of FH Europe. FH Europe, it's an organization interested in the citizens and patients with FH and other dyslipidemias. As well, I'm the founder of the Center for Innovation in Medicine based in Bucharest. And I'm as well involved with the International Consortium for Personalized Medicine as head of the Working Group for Education, Empowerment and Engagement. And I will refer too many hats, but the same interest actually to put every citizen, every person in the center, and to identify innovative tools in order to keep them healthy or to make them healthy again. And one of my quotes is this one, coming from my passion for sports. It's coming from Wayne Gretzky, who said that I skate to where the puck is going to be, not where it has been. And 1 year ago, actually, the puck was in the offices of the European Commission of the DG Santé, looking for new ideas for cardiovascular diseases. As a follow-up of the European Commission interest, involvement in development of the European Beating Cancer Plan, Cancer Mission, and all the involvement around COVID. And I have been very happy to be invited, both on behalf of Center for Innovation in Medicine and FH Europe, to discuss about new approaches, innovative approaches in the cardiovascular health. And I was very happy to see that the first area defined by the European Commission where intervention are needed is on cardiovascular diseases and related risk factors. And this is a conclusion of the stakeholders consultation last year, and this is reflected now in the Healthier Together initiative we have seen in June, and this reflected in the EU for Health calls just launched few days ago. On our side, on FH Europe, we worked very hard in the last 2 years. Actually, with the Slovenian presidency, we organized a technical meeting last October, and the outcome of this meeting is the publication in the European Journal of Preventive Cardiology, the publication around the need for pediatric screening for FH. It's a public policy background and a recommendation for this. Just to say that we follow up this year in Prague at the beginning of September with another meeting, and with the Prague Declaration. The time is now achieving FH pediatric screening across Europe. Of course, you can sign the declaration, you can endorse the declaration. It's in the public domain, so it's up to you to sign it. Just to say that for FH is not something new. 25 years ago was a call of WHO for FH screening, but in the meantime are just a few member states, to refer to Europe, that implemented, and Slovenia is one of the best examples to show that, but most of the countries actually didn't follow the recommendation, didn't follow the science, didn't follow the new approaches when it comes to screening and early detection and prevention of the cardiovascular diseases. The need for innovation in CVDs or CVH, I think, is clear. We have data regarding the share of avoidable deaths in the light of the current medical knowledge and technology in the member states, and we can see that 1 out of 3 deaths can be avoided at the EU level. Unfortunately, my home country, Romania, scored the poorest. Actually, 1 out of 2 deaths can be avoided. But on the right side on the screen, you can see that actually the main contributors to the avoidable deaths are ischemic heart disease, cerebral vascular disease, and then some types of cancer and hypertension disease. So there are a lot of cardiovascular or cerebrovascular, like stroke diseases, that contribute to these avoidable deaths. This implied the need for innovation, and I think the innovation is now a competency necessary for everybody is working in this area of healthcare, no matter what is the role. I think it's our task to innovate in order to improve the prevention, the early detection, the screening, diagnosis, and treatment in cardiovascular diseases. But the adoption of innovation is not an easy task. Actually, are just a few innovators, 2.5%, very few early adopters, around 13%, and it's, I can say this, is our task to convince the early majority and as well the late majority to follow the innovation. And why it's so important? Because we discuss about prevention, and prevention is linked with citizens, with healthy people, and we have to find ways to engage with them and to convince them to be part of our medical programs, medical interventions, medical approaches. But this gentleman, James Watson, I had the chance to meet him 10 years ago, was the one, together with Crick, who described the double helix of DNA, opening actually the era of genomic medicine, of genetics, first of all, then of genomics medicine and personalized medicine. And I think we cannot split the fourth industrial revolution with all these developments and data generation and a lot of tools. We cannot split the personalized medicine and I think the personalized medicine, in fact, it's the industrial revolution 4.0 reflection in the health and in the medicine. And I was very happy in 2015 to read the Council of the EU recommendation in December 2015 on personalized medicine, and to see a definition of the personalized medicine, like a medical model using characterization of individuals' phenotypes and genotypes, like molecular profiling, medical imaging, lifestyle data, and so on, for tailoring the right therapeutical strategy for the right person at the right time, and or to determine the predisposition to disease and or to deliver timely and targeted prevention. So we have this definition for almost 7 years, referring to personalized medicine. I will refer a bit to the developments in the field of cancer. Just to mention on this slide that soon after, in 2016, we organized in Bucharest, in partnership with the Romanian president, the first personalized medicine conference. And why it was so important? Because on one side, we started a discussion about cancer as a priority at the EU level. And we follow up in 2019 during our presidency of the council. And on the other side, we built at the local level the environment to put personalized medicine at the core of the current national cancer control plan, and hopefully prevention strategies for cardiovascular diseases. I said that personalized medicine is about people, and people, citizens, should be in the center, and we should be aware that are a lot of health determinants that influence actually our health status. And it's very, very good to be able to, in addition to the traditional risk factors mentioned as well by Florian, with the tools that I mentioned coming from the data space, from biotechnology, to be able to add additional data, additional biomarkers, in order to be able to stratify and to better profile the citizens. So, but on top of this, and you can see on the left side, there is this 24% of the health determinants referring to social circumstances. So we should take into consideration the, let's say, the environment people are living, who are the influencers, who are their members of the family or friends or neighbors that might influence their behavior. And of course, 36% is the individual behavior. What I'm saying this because if we have, and there is a lot of work behind Lp(a), it's a lot of work around FH testing, FH screening and so on. But if we'll not be able to understand people and to work at the society level, to use social innovation and to be able to assess the attitude and perception and to understand the behavior, actually we'll not be able to discuss about innovation, but to discuss just about a new tool to put in evidence a certain molecule, a certain biomarker. So as a part of the personalized medicine building ecosystem, I think this idea to focus on these social sciences and humanities part is a key one. And another important part is the one referring to the data. And in the near future will be a great challenge to implement in all member states, actually, the European health data space that will put in our hands, in the citizen hands, actually the control of the health data. This is very important. There are actually the health data treasures, and we should be able, again, to understand the people, to communicate in the proper way with them in order to understand the value of this type of innovation. In 2016, starting with the cancer, we organized, actually put in place a national survey, and through other questions, we asked people if they heard about personalized medicine in our country. And the percentage was 30% in 2016, 44% in 2018, and decreased to 41.9% in 2020. And we tried to explain actually why this was happening. And the explanation we identify for this decrease of the awareness is the infodemia, where a lot of communication around the health, but for the people, it was very difficult to identify what is relevant for personalized medicine in this informational space. Of course, in 2018, we asked specifically, have you ever heard about biomarkers? And you can see that we have around 42% of the citizens saying that they are aware. We didn't enter yet into more details. We just like scratching the surface in this field. So for personalized medicine, definitely we need a personalized communication, who actually can be summed up like the right message to the right person at the right time. But it's not so easy to implement personalized medicine in the health system, and this is a big challenge as no matter what therapeutic area is. And this is a sum up, and I can put in the chat the link to this publication. I was part of this, trying to identify the building blocks for personalized healthcare, and to identify the planning and enablers, as well the health information and IT infrastructure, of course, health services and health products with all what it means, the legislation, the regulatory framework, the pricing, reimbursement, access, innovative payment models, and so on. So might look complicated, I'm sure about that, but we try to put in this format what are actually all the challenges in front of the implementation of personalized medicine or precision medicine in the health system. In the cancer domain, and this is another scary slide, but I just wanted to point this, that part of the Beating Cancer Plan and Cancer Mission are part of this are some very specific personalized medicine actions, flagships and priorities, just for your information. And I would be very happy to see and to contribute to in the conversation around cardiovascular health, to be able to define this type of initiative, this type of potential actions, some of them that might be driven by the European level, others by the member states, and some of them by the civil society, and of course with the crucial role of the patient advocacy groups and healthcare professionals. I will try to summarize my talk, saying that probably in the cancer field, we are in this haute couture approach, especially with the CAR-T therapies more and more used. I'm sure that for FH and for LP(a) and for this new era of cardiovascular health, precision cardiovascular health, we are slightly moving to this pret-a-porter approach with the challenges I already mentioned when it comes to the implementation in the healthcare system. And we have to admit that most of the therapeutical areas and most of the health systems are actually in the old already paradigm that one size fits all. So we have this mix of realities. We should be able to learn from other experiences, from other therapeutical areas. And I think the key example coming from cancer, when it comes to the challenges of the implementation of the LP(a) testing, is to try to do it in the best possible way from the beginning in order to avoid the inequalities. On cancer is something we see now with every biomarker and every new genomic test coming to the market. Actually, the East-West divide, to refer to this, the East-West divide is even broader with every innovation. So for the cardiovascular health and cardiovascular diseases, we are now in a very good position to start actually from zero, to build a model that is inclusive and will avoid the inequalities. This is my last slide because I'm part of the IC Permed I mentioned from the beginning, and we expect next year in 23 to start the European Partnership for Personalized Medicine, and this I think will create the foundation for a unified approach of the implementation of personalized medicine across Europe. Of course, we'll have enough time to discuss about this, but the idea is to improve the health outcome for citizens and for patients. And you can see that is highlighted in the vision, this idea of the benefits of patients, of citizens, and of the society, and of course, having in mind the burden of the cardiovascular diseases. I think if we'll be able to implement this in the cardiovascular disease area, the societal impact will be the positive impact will be a very important one. My last message is that the electric light did not come from the continuous improvement of candles. And I think we are, with the LPDLA, of course, with FH and other developments in this field of cardiovascular health, in the position to invent the electric light, even despite the fact that this is quite a challenging discussion in practical terms in Europe in this wartime. So thank you so much once again for the invitation, and I'm very happy to answer any questions.
Thank you so much, Marius, also for a great presentation and lots of messages coming from there. You know, for example, the need for innovation in cardiovascular disease, and thinking about that from a prevention, early detection and screening and treatment perspective, needing to build that environment for personalized medicine. And of course, drawing the comparisons several times with experience with biomarkers in oncology, you know, for the lessons learned there. So, and not to forget your call to signing the Prague Declaration. So many interesting topics covered there. And just a reminder to submit your questions to the Q&A box, and we will address those in just a few minutes after our next speaker, Lina, has given us some industry perspective. So thanks, Marius, and over to you, Lina.
Thank you. Can you hear me well? Can you hear me?
Loud and clear.
Great. Thank you. So my name is Lina, and you said it very well, Limberopoulou. I'm the head of global policy for cardiovascular disease at Novartis, and it's really a pleasure to be with you today. And I want to congratulate you since you gathered really the three key perspectives around this table. So the patient voice, the clinician voice, and perspectives, as well as the industry. After these two very informative presentations, I'm not going to use slides, but it's a nice segue from Marius in terms of, okay, we know Lp(a) is an important biomarker. We have a lot of data around that, FH and FH screening. The problem is, how do we translate the science and the latest scientific knowledge? How do we integrate those biomarkers into public policies to really make a change? So we often see many, many guidelines out there. The problem is that doctors are not adopting those guidelines as quickly as possible. And therefore, you know, we don't have the right environment for the innovation. So I'm going to talk a little bit and give our perspective on how we can accelerate public policies for that. And if I step back a little bit, first of all, we need to remind ourselves that it's remarkable that we see CVD accounting for more deaths every year than all cancers combined. And in fact, also more than all COVID deaths so far over the past 2.5 years. So today we have 18 million deaths from cardiovascular disease, 300 million people affected worldwide. And we've seen a big decline over the past several decades, but alarmingly now CVD deaths again are on the rise. So we need to really send a strong message to our politicians, to the patient community, that we need to work together to bend this curve. Otherwise, we're likely to see one of the biggest, largest healthcare crises that the systems will need to cope with. The good news is that 80% of the CVD deaths are preventable, and we know how to prevent these. And in my daily work, I'm trying to learn from other disease areas which have been really successful in clinical and patient community policy and advocacy. And clearly cancer stands out. And in fact, today, Marius, you were alluding to the cancer beating plan. they've been extremely successful. And I was looking from a policy perspective, what is the Google trending in the last 12 months when you type CVD policy versus cancer policy, and clearly you see the curve of cancer policy Google trends being much, much higher than CVD. So, you know, we've been looking with the industry, what are the root causes? And how can we change that? And there are multiple reasons. First, CVD being less emotional, but also the stigma around patients not living a healthy lifestyle. And there is a perception that CVD is just about lifestyle, exercise, diet, and if you do all the right things, you know, you will control CVD, but actually we know it's much more than that. So first, we need to change the perception out there that CVD is a lifestyle-driven disease. The reality is that it can also be inherited, like we heard today, FH, as well as high Lp(a) levels. And in fact, Lp(a) levels are very common. It's affecting 1 in 5 people in the normal population. We have seen and heard from Florian that there are several guidelines that recommend testing for Lp(a) at least once in a lifetime. And yet, and even then, testing Lp(a) is very simple. It's a blood test. It's not a genetic test. It's very inexpensive and it's reimbursed by most of the government. And yet, it's not routinely tested in clinical practice. In fact, it's only 1% of people that are tested today. So how can we increase the testing rates up to 50% at least if we want to bend the curve of CVD and tackle Lp(a)? And even though today we don't have targeted therapies, there are many clinical trials under development. But as we heard from Florian, there is a concrete value of knowing your levels today. So there is opportunity for cascade familial screening, for re-stratification of the CV risk of patients, and take clinical decision based on their overall risk score. This is the only way we can really prevent cardiovascular events such as heart attacks and strokes. Second, I would say we need to raise political awareness that 80% of deaths can be preventable, and highlight what interventions are there that can address the humanistic and the economic burden of CVD. So we need clearly a political will and commitment to concrete national CVD plans with very concrete targets, clear healthcare pathways for patients. But we also need policies at healthcare system level that introduce the correct incentives. So we would need incentives for doctors to diagnose patients for early detection rather than penalizing them for eating up their diagnosis budget. We also need incentives for patients to test for Lp(a) and to know their numbers rather than being penalized by health insurance plans. So that's also another big topic that we need to work all together around. Thirdly, we need to think differently on how we transform care and how we deliver care. And we will need to work differently also as an industry and government. So we need to move away from this transactional approach where we launch a medicine, we get the price, it's reimbursed, and then we're hoping that the medicine will be reaching the patient. Instead, we're proposing a more holistic approach where really the public and the private work together to reach a common goal. So this is such a big area that no company and government or healthcare system can tackle alone. And we're really happy to see how we can work together around a whole ecosystem. And we're really part of this debate. We recently also supported an initiative at the World Economic Forum, which with a paper on how public-private partnerships can accelerate cardiovascular health. And I encourage everyone to also have a look at this paper so we can accelerate a different way of delivering care. Now at European level, the good news is that we have, as we heard from Marius, in June, the Healthier Together initiative on NCD was launched by the European Commission, and this is clearly putting a focus on cardiovascular disease and diabetes. So we have a renewed political attention, and we need to build on this momentum, but it's not enough to have an NCD roadmap. We really need to be very specific about what we're asking in terms of CVD screening at European level. And the debate on CVD screening is only starting. And we're working with European stakeholders like the EACH Alliance, FH Europe, and many other stakeholders to come up with a common approach on CVD screening, which would include FH screening, would include Lp(a), cholesterol, BMI index, hypertension, and diabetes. And this is how we can really bend the curve around CVD. If we all work together around all these important risk factors. So at Novartis, we're committed to working with all of you for really targeted screening strategies. And we have an opportunity, as I said now, to unveil the invisible and prevent many heart attacks and strokes in the short term. So with that, making the invisible visible is the key to tackle CVD.
Thank you, Lena, and for also this great soundbite, which I hope makes its way to social media immediately. So we should have had some time for Q&A, and I do see a couple of questions that have accumulated in the chat box. So I'll accumulate them together. So one question we had was, does LPA concentration stay constant over life? And I guess a related question is, what is the recommendation, perhaps as a reminder, for LPA screening? Is it everyone? Is it age-based? Is it based on risk factors? And then I'll add in one question I had myself is, and perhaps we don't have time to address this, but how can we address this East-West divide that emerges, then that will emerge with biomarker testing in cardiovascular disease? So Florian, I don't know, maybe you want to take the first question, and then Marius, maybe the East-West divide.
Yeah, when measurement of Lp(a) Lp(a) is relatively stable over life, yeah, and therefore we can say at least once a measurement should be enough. There are some exceptions, but if someone has a concentration of 3 milligrams per deciliter, it will not go up to 20 or so. So therefore we can measure it only once. And in earlier times, the recommendations were very complicated in whom to measure Lp(a). We step back now in the new consensus paper, and also other recommendations from other societies say that in everybody it should be measured, because otherwise you are waiting till something happens and then you start to measure. And a certain number of cardiovascular events are already deadly when they occur the first time. So measurement in everybody is, I think, a good recommendation, and guidelines will only be followed when they are not too complicated. And we try to make it simple.
Thank you, Florian. Marius, do you want to have a stab at the East-West divide?
Yes, and this is actually a topic of high interest for me living here in the East, and we work a lot, of course, on cancer as well, on COVID, and especially on COVID-19 vaccination, as well on HPV vaccination, and we actually identify a new iron curtain dividing Europe, but this time is a reality, in fact, with all or almost all aspects of related to the health and health innovation. And of course, is the history, is the past communism history for most of the countries in the region. and this is correlated with the poor outcomes of COVID, the highest number of deaths, especially in the Delta wave or where in our region. So, and I have seen some studies linking this with the post-communist status. So this is on one side. The other point is the structure of the health system. Most of the health system are actually hospital-based, are designed to treat patients, not to prevent the disease. So to Lena's point, indeed, we should restructure this and to find the right incentives for family doctors and anyway, before the hospital, ideally the community level, to find the right incentives for the people to join the prevention program. So we have this lack of, let's say, prevention culture. And this is an historical explanation, but is this fact, and this is related, it is always highlighted by the European semester analysis. So, every year, actually, European Commission is saying you should move from hospitals to community to society to primary doctors. And this, the individual behavior, I already mentioned this. And I think there are some solutions. One solution is actually to use all the synergies we have at the local level. We cannot wait from Brussels to say to people from, I don't know, from Budapest or from Belgrade or from Sofia to tell what to do in terms of prevention when the cultural factors are so important for this. So it's very important to build local ecosystem and to use all the synergies. Regarding the doctors, we need common curricula, you know, for doctors, for young doctors, to have a common understanding of the current status, and especially in the area with a high degree of innovation. Regarding the incentives, we should pay for the prevention, not to pay for, you know, for each intervention at the hospital level or the ambulatory level. So the fourth point is the use of data. I will not enter into details because we should extend to maybe 2 hours our discussion, but the use of data through the citizen involvement. And this is very important. And the fifth is, you know, we should have the power of as people living here that we should learn more from the people who already are in the position to teach us. And for these projects like the twinning ones and the teaming, anyway, under the umbrella of the widening in Horizon Europe, are the type of projects that could help us to close this gap.
Thank you so much, Marius, and thank you to all of our speakers and all of our attendees. I'm afraid we've gone over time, so we'll have to close the session here, but it's clear that the discussion on this topic is to be continued, and we invite you to share the recording of the webinar with colleagues, peers, and your network, so we can continue the discussion in the virtual platform. So thank you very much, everybody.